the introduction, let's go to the basic. We know that the twin pregnancy increase with assisted reproduction technique. It's more in the advanced age. Yeah, the risk is about 1 in 80 to 100 pregnancies. Okay, and then it's 3 to 5 times higher risk than singleton pregnancies. Of course, in this lecture, I don't talk about the higher order, the triplet, the quadruplet, but you know, whenever the patient having higher orders of pregnancy, the risks are more compared to the twin pregnancies. So we know this is the summary. You know that in ERP, increased incidence of multifetal pregnancies. Yeah. Advanced maternal age, increased risk of aneuploidy, and also structural anomaly, and twins 3 to 5 times higher risk compared to singletons. Again, basics. Okay, we know that this is a monozygotic, 1 sperm, 1 egg, shared placenta. So this is monochorionic. This is dizygotic. Okay, dizygotic, they have dichorionic. Okay. This will tell you the complications that may occur depending on the time of the cleavage. You know that whenever the cleavage occurred at day 1 to day 3, at the level whenever the morula occurred, so you will have dichorionic, diamniotic. Whenever the patient comes to you with twin pregnancy, we always hope that the patient will have this type of twin pregnancies because we know it has less complications compared to the others. Okay, but whenever the cleavage occurs on day 4 to day 8, at the blastocyst period, you may have monochorionic, diamniotic. Yeah, 1 placenta, 2 sets. Okay. At the level of implanted blastocysts on the day 8 to 13, you will have monochorionic and monoamniotic. At later days of cleavage, on day 13 to 15, when the embryonic disc already formed, unfortunately the patient will have conjoined twins. So, now again, go back to the basics. Chronicity to determine the chronicity is very important. That's why the first doctor who diagnosed the patient as having twin pregnancy, we really rely on you to determine whether it's dichorionic or monochorionic. Okay, so it's very important. Usually, most of the time, we make diagnosis during the first trimester or early second trimester. You know that for dichorionic, you will diagnose whenever from the ultrasound you have lambda or twin peak sign. I will show you the photo of this. For monochorionic, T sign at the membrane insertion. And if you're lucky, let's say the patient came to you later because the patient had a late booking, and you noted that one baby is boy, one baby is girl, so you know that the pregnancy is a dichorionic twins. Okay, this is showing you the lambda sign or twin peak sign. Yeah, this is a lambda sign. Okay, it's quite clear, very clear. So this is dichorionic. Okay. T sign. Whenever you try to look at the, I don't think it's right. It's not very clear. Yeah? It's not very clear. But you try to look at the insertion, the membrane attachment at the placenta. You cannot see the lambda sign. You just see the T sign. So this is monochorionic. But of course, you need to refer the case to the hospital, to the Shirley Center for confirmation and for the follow-up later on. Okay, complications. Remember, we are dealing with the mother and the fetus. For the mother, you know that the mother, because of the increased beta ICG, you know the mother will have hyperemesis gravidarum, usually more severe than the singleton pregnancies, anemia, preterm labor. For preterm labor, you know that about 50% the patient will end up, 50 to 60% will end up with premature delivery. So we have to prepare the patients we will, for this problem, usually we advise the patient to receive RM dexamethasone for the fetal lung maturity from 26 to 28 weeks. Yeah, usually we advise the patient for the dexamethasone. And you know that for the lady with a twin pregnancy, the patient will have a risk of hypertension, gestational diabetes mellitus. So don't forget to screen for the GDM. Polyhydramnios, especially whenever the patient has complication of twin-to-twin transfusion syndrome, or one twin end up with abnormal fetus, the patient might have polyhydramnios, which again will lead to the premature labor and delivery. And to the fetus, we will have discordant growth in the case of a selective IGR, or twin-to-twin transfusion syndrome, premature baby, premature delivery, SOT anomaly, more common than singleton babies. Again, chromosomal abnormality, the risk is about 8 to 10%. In monochronic, it's more compared to the diachronic pregnancy. And twin with one fetal death. Okay, structural and chromosomal abnormalities in twin. It's rare, but it can happen. Okay, major malformations from the study, it shows that about 2.12% in twin pregnancies compared to 1% in singleton pregnancies. The major malformations such as the neurotube defect, congenital heart disease, in which when you diagnose, we have one is the counseling and what is the plan of the management for the patient after that. Okay, the minor malformations, about 4% in twin pregnancies and 2.45% in singleton pregnancies. Okay. We know that malformations are higher in monozygotic twins, about 3.1% compared with dizygotic twins, about 1.9%. Okay, these are the more common structural abnormalities in twins, neurotube defects such as anencephaly, hydrocephalus, spinal bifida, bowel atresia, and cardiac abnormalities. Recently, I had one case from Kulim. The ONG specialist referred to me DCDA twin with one abnormal baby. Sorry, MCDA twins. When I saw the baby, it looks like anencephaly, but of course, in my mind, I need to rule out TRAP. Twin reverse arterial perforation. Later, I will discuss on TRAP. But when I look properly, I still can see the fetal heart clearly, except that the fetus is acranial. So I know that the other baby is grossly normal, and then the other baby is anencephaly. So what are the plans for this pregnancy whenever you have one baby with lethal anomaly? You know that this baby cannot survive. And you need to remember that the patient can have complications such as polyhydramnios, which will end up with premature delivery. Usually we give option to patient, of course in our society, because we know that the other baby is grossly normal, we need to inform the patient regarding the risk of premature delivery, premature baby. One, conservative management, or maybe if that sac end up with polyhydramnios, maybe you can consider serial amnioreduction to prolong the pregnancy, or maybe you can consider, but not in our center at the moment, you can consider fetoscopic laser ablation of the umbilical cord of that baby, so that we can focus on the normal fetus. Okay, maybe in it's quite rare, but in some of the country they will do termination of pregnancy straight away for both the baby. Okay, so for this patient, I'll consider more on conservative. If the pregnancy end up with polyhydramnios, they may refer back to me to consider the amnioreduction. Okay, now problem specific to monochorionic twins. We know that one of the complications, twin-to-twin transfusion syndrome, monoamniotic twins, twin reverse arterial perforation sequence, and conjoined twins. Twin-to-twin transfusion syndrome. Okay, it complicates about 10 to 20% of monochorionic pregnancies. and responsible for about 15 to 17% of all neonatal death in twins. Okay, how it occurs? It usually occurs in monochronic and rarely in dichronic twins. It occurs when there is vascular connections between the two placentas. Yeah, it's more arteriovenous. Okay, anastomosis within a monochronic placenta compared to the dichronic. It can either arterial, or can be also vein to veins. Yeah, but usually the one that gives more problem is the arterial to arterial. Okay, because of the connection between the vessels, the one fetus will receive more blood compared to the other fetus. Okay, diagnostic criteria for twin-to-twin transfusion syndrome. Okay, it's actually asymmetrical fluid distribution and growth in the sex and the fetus. So you have to look at whether it is oligohydramnios or polyhydramnios. Usually based on deepest vertical pool. You know that the normal DVP for twin is between 2 to 8. So if one sac, the DVP, the deepest vertical pool, is less than 2, is considered as oligo, and the other sac, if it is more than 8, is considered as polyhydramnios. Yeah, oliguria in donor, smaller donor twin, yeah, intrauterine growth restriction, and later on you can have abnormal Doppler. But mind you that the anastomosis is not only at the superficial surface of the placenta, it also can occur deep. Yeah, this is the superficial surface, and this is also deep anastomosis. That's why if we refer a case for fetoscopic laser coagulation, usually we will ablate the superficial anastomosis. Yeah, we can't really, of course we cannot see the deeper anastomosis. That's why after the fetoscopic laser ablation, recurrence may occur. Okay, this is the diagnostic criteria for TTTS. It's based on the Quintero stages. Stage 1, bladder of the donor twin still visible, only poly or oligo like what I informed just now. Okay, bladder, stage 2. Stage 2, bladder of the donor twin no longer visible. Yeah. That's why whenever we have a case suspected for twin-to-twin transfusion, even though we already had detailed ultrasound for the babies before they came with a TTTS, we still have to look at the fetus. We look at the bladder, whether it's present or not. We look at the heart, okay? So that in the stage 2, if the donor twin doesn't have bladder anymore, so it's considered as stage 2. Of course, it has a bladder, but it's not expanded, okay? It's not extended, okay? The stage 3, critically abnormal Doppler. Whenever you have abnormal Doppler, this is already stage 3. Stage 4, you have hydrox fetalis, yeah, pleural effusion, ascites, pericardial effusion, yeah. Stage 5, demise of one or both twins. Okay, now what happened? This is the recipient, okay, this is the recipient, fetus. This is the donor twin. You see the recipient will have volume overload, okay, polyhydramnios. The baby can have cardiomegaly because of the cardiac compensation and end up with hydrox fetalis. While the donor twin will have oliguria, oligohydramnios, IGR, and later on end organ damage. Okay, what's the treatment? Okay. The treatment, one is serial amnioreduction. Yeah. Second is amnioseptostomy. But in the first and the second method, we do not treat the cause of the TTTS because we don't touch the vascular anastomosis. We just treat the results of the TTTS. Okay. But the actual treatment is the laser photocoagulation of placenta anastomosis. Okay, just to show you, these are twins. Twins also can have different personality. The other one very happy, telling people we are twins. But the other one, a bit naughty, he's the evil one. Okay, So twin maybe can have same face, but they will have different personality. Okay, serial amnion reduction. This is for the treatment. I will discuss briefly of each of the management. The amniotic fluid. You know that one sac will have polyhydramnios, okay, and later on will end up with premature delivery. So we'll try to remove the amniotic fluid under ultrasound guidance, and we remove, if possible, until the deepest vertical pool is less or equal to 6 cm. Even though this photo I took from the internet, not very clear, but I like to see the result of the amnion reduction. This one is trying to show that this baby, this fetus, the recipient with the polyhydramnios, after the after the amnion reduction, so because of the less tension in this sac, so the fluid in the other sac, the life core is now better compared to before we did the amnion reduction. So temporarily we may remove the tension there. Okay, that's the effect of the amnion reduction. So how about amnioseptostomy? It's actually intentionally puncture the intertwin membrane. We puncture the intertwin membrane to create the connection between both gestational sacs. So it allows the amniotic fluid to cross into the stuck twin sac to allow the equilibrium of the amniotic fluids between the gestational sac. Again, we don't actually really treat the cause of the TTTS. Okay, fetoscopic laser photocoagulation. This is the third management for the TTTS, performed under general or local anesthesia, using the endoscope. We use the laser energy to obliterate the anastomotic vessels. Okay, see this photo. So whenever we insert the endoscope, we try. This is the fetus, the recipient fetus, bigger. This is the donor, which is smaller. We try to look at the placenta and search for the anastomotic vessels and ablate that vessels. But of course, we only ablate the superficial vessels. We cannot identify the one that inside the placenta, the deeper one. Okay, this is the basic part of the fetoscopic laser ablation. This is from the endoscope. Okay, they search for the artery or vein, which is anastomotic, and then they ablate the area. This is after the ablation. Yeah, this is after the ablation. Okay. Okay. Now we go to the twin reverse arterial perfusion. So finish about the twin to twin transfusion syndrome briefly. Okay. After the fetoscopic laser coagulation, of course, before the procedure, we will tell the patient what are the risks of the fetoscopic laser coagulation. The risk one is leaking, PPROM, which may occur in about 10 to 20% of the cases. Yeah, and of course end up with premature delivery. And we need to also to inform patient that there will also risk of recurrence. Okay, whenever we send, for example, last time I sent 2 cases from Sungai Petani to Ipoh for fetoscopic laser coagulation. After the procedure, the case was sent back to me for monitoring. We'll try to prolong the pregnancy, but unfortunately, one of the patients ended up with delivery before 28 weeks. She delivered about 1 week after the procedure. Usually, we did the procedure between 16 to 26 weeks. The first lady unfortunately had preterm delivery at about 26 weeks. The other lady, we managed to prolong up to 29 weeks. Yeah, and both the babies survived. And we also need to explain to patient, even though we managed, after the procedure, we managed to prolong the pregnancy compared to the time when she had the complication, but the baby need to continue the follow-up, the risk of severe prematurity, need longer follow-up with the neonatologist after delivery. Okay? So now we go to the twin reverse artery perfusion, another complication for the twin pregnancy. It's about 1% in monochorionic twins. The incidence is about 1 in 35,000 births. And the problem is that the acardiac twin, the abnormal twin, receive the blood from the normal fetus or normal palm twin. Okay, what is it actually? So, in twin reverse arterial perfusion, okay, in the abnormal fetus, there is no cardiac structures or activities. Okay, often no identifiable cranial structure. A glance, you thought that is anencephaly, but actually whenever you see that there is no fetal heart activity, actually this is trapped twins. Okay, there's also presence and structures of the upper extremities is variable. Sometimes you can see both hands, sometimes you cannot see, very short or just parts of the upper limbs only. You can see the body, the torso, and the lower extremities clearly. And most in 60% you can have single umbilical artery, and of course because of the abnormal fetus you can have polyhydramnios in that site. So how do you diagnose from the ultrasound? Okay, this is focusing on the acardiac twin. You can see the body, the torso, the lower limb. Okay, you try to focus on the fetal heart. There is no fetal heart activity. Yeah. So this is the ultrasound showing the two fetus. This is the acardiac twin. This is the normal fetus, which is the palm twin. Okay, what the management? Ideally, the management is the occlusion of the blood flow to the acardiac twin by endoscopic ligation or laser coagulation of the cord. So whenever we occlude the blood flow at the cord that going to the acardiac twin, so we stop the anastomosis, we stop the blood flow to the acardiac twin. Okay. But the other option is that in conservative management, where you prepare the patient with a dexamethasone and try to deliver, and we deliver earlier. Yeah, try to prolong the pregnancy as near term as possible. But if the patient had polyhydramnios, usually most of the time we deliver at 32 to 34 weeks. Luckily, that this case is very, very rare. In monochorionic monoamniotic twins. Okay. As we know that the splitting of the embryo after day 9 will result in monoamniotic twins, 1% of all twins. The fetal loss rate is about 50 to 75% due to fetal malformation, premature delivery, and complications arising from the close proximity of the two cords. You know that this pregnancy has only one placenta, one sac, yeah, only one room, but two babies inside there. Yeah. So about 50% of the fetus will end up with IUD if you prolong the pregnancy until term. The reason is that after 32 weeks, the risk of the cord entanglement because they are staying in one sac, the risk of the cord entanglement after 32 weeks is higher. That's why in monochorionic monoamniotic twins, whenever the patient reach 32 weeks, 32 to 34 weeks, we usually will advise for delivery because of the risk of IUD secondary to the cord entanglement. Okay, so I'm trying to show you. After delivery, you can see there is only single placenta. Okay, single placenta. You can see that the two fetus very close together. You can identify the separating membrane. Okay. This one from MRI. Okay. This one showing you the cord entanglement. Okay, cord entanglement. Okay. How we monitor the cord entanglement before the time of delivery? Frankly, it's difficult. Okay. But if possible, every time the patient comes to us, we'll try to do umbilical artery Doppler, which may suggest, even though it's not 100%, it may suggest that the insult is occurring. This one is after delivery, showing you the cord entanglement. Okay, this is in in the first trimester, which shows the absence of the dividing membrane between the two fetus. Sometimes, you know that in monochorionic twins, MCDA, because of the separating membrane is very thin, because they have only one chorion, one amnion. Yeah. Sometimes in the first trimester, it's a bit difficult to identify the membrane, the separating membrane. Usually, we will repeat to confirm whether the pregnancy is MCDA or MCMA. Yeah. Okay. Sometimes you cannot see in the separating membrane in the first trimester. Okay. This one showing you the cord from each twin and the entanglement in the middle. So this one confirm MCMA. Okay, now after this we go to the conjoined twins. Okay, the conjoined twins, from the ultrasound features, we know that the fetus is inseparable. Even though you wait, you give some time during the ultrasound, you can see that the fetus is still close together, inseparable. It's a monochorionic twin. Okay, there is no intertwin membrane, and you can see the hyperextension of the cervical spine. Means that the position of the fetus is quite odd. Yeah. Okay, with unusual limb positioning. So let's say in the first trimester or whenever the patient comes to you for the first time, you can see that the position of the fetus is quite different or quite odd. Just refer to the tertiary center for confirmation. Okay, this one showing you the conjoined twins. Okay, conjoined twins. Okay, very close together. This one also close together. Okay, I think I missed the type of twins just now. Okay, this is show you the type of twins, thoracophagous. This is the one at the level of the thorax. Okay, but it's separated. Phallophagous. Okay, one at the level of the abdomen. Brachyphagous at the back. Okay, the other one, this one is pygophagous. Okay, circulation. Okay, this one is the ischiophagous. Okay, I think there are many types of the conjoined twins. Okay, we go back to the ultrasound. Okay, whenever you do for the conjoined twin, first you must start from the head to toe. You cannot just see one, just put the probe, that's enough. This is conjoined twin. You start from the head, you can see that the head, okay, you cannot see the separating membrane, so it's confirmed as monoamniotic. Okay, then you go down a bit, you can see that the spine is almost attached here, and then lateral view, you can see that the two heads and the spine is attached together. Yeah. Okay, then when you go down further, for this case, you can see that the spine here is separable, the head is somewhere here, and at the end here, at the spinal region, is again attached together. Yeah. So this may suggest to you that this is a conjoined twin. So again, this one you can see that at the level of the chest, you can see that they are sharing the heart. This is the thoracic cage, the thorax. Again, it's sharing the heart in the middle. Okay, this one. Okay, the spine. Okay, the spine here. The spine here. Okay, the head is somewhere here. Okay, sharing at the level of the thorax and the abdomen. Okay, this is the head. They are sharing the head. No? You can see. You follow the cranium. So follow the cranium. Okay, you cannot see the cranial line in the middle. Yeah, this one is sharing the brain. I don't know whether you remember this lady or not. This is about, I think if I'm not mistaken, in 2005 or 2007, I'm not mistaken. One is a lawyer, the other one is the writer. They want to get married, so they want to be separated. Okay. There is one Complications that I did not put the slides here. That is a twin with one fetal death. Yeah, twin with one fetal death. Let's say during the follow-up, it happened that let's say you're in the clinic kesihatan. It happened to you that you saw that there is no fetal heart activity in the one fetus. You must immediately refer to us. Usually, what we will do, we will counsel the patient the risk. First, we will look at the period of the gestation when the patient was diagnosed to have the one fetal death. The other one, we need to counsel the patient. We will tell the patient that the insult, because there are two main theories about the insult to the fetus in one fetal death. The other one is the transfer of the thromboplastin from the dead twin to the alive fetus. The other theory is about the hypoxia during the time of the death of the dead twin. Okay, whenever there is hypoxia in that twin, so there will be a hypotension, and that's the time where the brain of the alive twin will become hypoxia, and the insult will occur there and then. Okay, the risk to the fetus is about 8 to 10%. Okay, we must inform the mother if the insult is already happened at that time. So what usually we do, we give dexamethasone to the mother if it is after 26 weeks, and we try to prolong their pregnancy. We will consider delivery at 34 to 37 weeks. Yeah. Okay. So after that, the neonatologist, the pediatrician, will help to continue with the follow-up of the baby to monitor the how's the baby after the delivery. Okay, so now the take-home message is that the twin pregnancies may be associated with complications. You need to counsel the mother so that they will, because you know that in monochorionic twins, the follow-up is very frequent. The patient must come to us about every 2 weeks. Again, klinik kesihatan, the FMS. So we need to counsel the patient regarding the risk, the complications, so that their compliance is better. Yeah. Okay. We know that the chronicity is the main factor determining pregnancy outcome. So whenever you see the twin pregnancy in early stage, try to diagnose whether it is monochronic or dichronic. And then the proper assessment and diagnosis play an important role in managing twin pregnancies. Okay, this is a cartoon showing you during the fetoscopic laser coagulation. So one of the twins says, "Oh, that nearly scared me to death. I have a full bladder and a weak heart." You know, this is which one? The recipient or the donor? Recipient. Okay, so with that, I thank you.